Good morning, everyone, and thank you for being here today. I'm Dr. Asim Haseen, and I'm excited to welcome you to our discussion on infectious emergencies. Today, we'll be focusing on a particularly important topic, infective endocarditis. Over the next few slides, we'll explore its causes, diagnosis, management, and what you need to know to handle such cases effectively. Let's get started. Let's look at the question here. We have a 61-year-old man with a mechanical aortic valve who presents with fever and acute confusion. Blood cultures have grown Staphylococcus aureus. Now, the question asks, which feature most strongly supports infective endocarditis? On the table, we see several options. Fever above 38 degrees Celsius, positive blood culture with S. aureus, elevated CRP, hypotension, and anemia. While each of these can be associated with infections, some features are more specific for infective endocarditis. For example, a positive blood culture with S. aureus is significant because this organism is a common cause of endocarditis, especially in patients with prosthetic valves. Elevated CRP indicates inflammation, but is nonspecific. Fever is common in many infections, but alone, it doesn't confirm endocarditis. Hypotension and anemia can occur in various severe infections, but are less specific. So, in this context, the most compelling feature supporting infective endocarditis is the positive blood culture with S. aureus, especially given the patient's prosthetic valve. Recognizing this helps us focus on the diagnosis and subsequent management, which is critical in these cases. All right, let's talk about why answer B is correct here. When dealing with S. aureus bacteremia, especially in patients who have prosthetic valves, the risk of infective endocarditis is significantly higher. This means we need to be very proactive. Urgent echocardiography becomes crucial in these cases because it helps us detect any potential valve involvement or complications early on. Recognizing this high-risk scenario allows us to act quickly and appropriately, which is essential for improving patient outcomes. So, the key takeaway is that in cases of S. aureus bacteremia with prosthetic valves, prompt imaging is not just recommended, it's mandatory. All right, so here we have a scenario where a patient is suspected of having infective endocarditis, but the initial transthoracic echocardiogram, or TTE, didn't give us a clear diagnosis. The question is, what's the next best step in investigation? Now, looking at the options, the key thing to remember is that TTE can sometimes miss small vegetations or certain complications, especially if the image quality isn't ideal. So, when TTE is non-diagnostic, the next step often involves more sensitive imaging techniques. Option A suggests repeating the TTE in 2 weeks, but if the initial one was non-diagnostic, waiting might delay diagnosis and treatment. Option E, a PET scan, is more useful for detecting metabolic activity, but it's not the first choice here. Option D, a CT coronary angiogram, is great for coronary artery assessment, but not primarily for endocarditis evaluation. That leaves us with options B and C. Cardiac MRI offers excellent tissue characterization, but is less specific for endocarditis compared to other modalities. Most importantly, transesophageal echocardiography, or T, provides superior visualization of cardiac structures, especially valves, and is more sensitive in detecting vegetations and abscesses. That makes T the next best investigation after a non-diagnostic TTE in this context. So the key takeaway is that when TTE doesn't give us the full picture in suspected infective endocarditis, moving promptly to T is the most effective step to get a definitive diagnosis. All right, let's look at slide 5. The correct answer here is C, which is marked with a check. Now, let's talk about why that's the best choice. Transesophageal echocardiography, or T, is actually more sensitive than transthoracic echocardiography, especially in certain scenarios. For example, when we're dealing with prosthetic valves, T provides a clearer picture and helps us detect issues more reliably. It's also particularly useful when there's suspicion of an abscess, as T can identify these complications more effectively. Additionally, If a TTE comes back negative but clinical suspicion remains high, T becomes even more valuable. So overall, T is our go-to tool in these situations because of its higher sensitivity. This point ties into the broader theme of choosing the most effective imaging modality to ensure accurate diagnosis and better patient outcomes. Now, let's take a closer look at this question. It asks, which complication of infective endocarditis requires ICU admission? Looking at the options, we have low-grade fever, splenomegaly, acute pulmonary edema from valvular destruction, elevated ESR, and microscopic hematuria. While some of these, like fever or splenomegaly, can occur in infective endocarditis, they don't necessarily indicate a need for intensive care. However, when we see acute pulmonary edema resulting from valvular destruction, that's a serious complication. It can lead to rapid respiratory compromise, and therefore, it's critical that these patients are managed in the ICU. This highlights the importance of recognizing severe, life-threatening complications in infective endocarditis early. By doing so, we can ensure prompt, appropriate intervention to stabilize the patient. So, the key takeaway here is understanding which complications demand ICU care, primarily those that compromise respiratory and cardiovascular stability, like acute pulmonary edema. The correct answer here is C, and let me explain why. When a patient experiences acute severe valvular regurgitation, it can quickly lead to pulmonary edema because blood is leaking back into the lungs, causing fluid buildup. This situation puts a lot of stress on the heart, and if it worsens, it can lead to cardiogenic shock, which is a state where the heart can't pump enough blood to meet the body's needs. Due to the severity of this progression, such cases require intensive care unit support to stabilize the patient. This slide highlights the critical importance of recognizing these signs early and understanding the need for prompt ICU intervention to manage such life-threatening conditions effectively. All right, let's look at this scenario. We have a patient who is hemodynamically stable, and we're suspecting infective endocarditis. The question is, what's the best approach to antibiotics in this case? Now, option A suggests starting antibiotics immediately without cultures, but as a general rule, obtaining blood cultures before starting antibiotics is crucial. This helps us identify the causative organism accurately. Option B recommends obtaining at least 3 blood cultures before administering antibiotics. This is considered the best practice because it increases the likelihood of detecting the pathogen and guides targeted therapy. Option C suggests giving only oral antibiotics, but in the case of suspected infective endocarditis, intravenous antibiotics are usually preferred initially to ensure adequate blood levels. Option D proposes delaying antibiotics for 72 hours, which could be risky because it might allow the infection to progress and lead to complications. And finally, option E recommends giving steroids first, but steroids aren't part of the initial management for infective endocarditis unless there's a specific indication. So, tying this all together, the key point here is that obtaining blood cultures before starting antibiotics is critical for proper diagnosis and management. This approach aligns with the overall theme of timely, targeted therapy in infectious diseases. Therefore, the best answer is B. Obtain at least 3 blood cultures before starting antibiotics. All right, let's look at this important point. The correct answer here is B, which means in stable patients, it's essential to always obtain at least 3 blood cultures before starting antibiotics. Now, why is that so crucial? Well, collecting multiple blood cultures increases the likelihood of accurately identifying the causative organism. This is key because it guides us in choosing the most effective targeted therapy. If we start antibiotics too early without proper cultures, we risk missing or misidentifying the pathogen, which can compromise patient outcomes. So, in the context of managing infections, especially in stable patients, obtaining these cultures beforehand really helps optimize our diagnostic accuracy and ultimately improves patient care. Now, let's examine the question carefully. It asks us to identify which situation requires urgent surgical intervention in infective endocarditis. Looking at the options, we see different clinical scenarios. For instance, option A mentions a fever persisting for 48 hours. While persistent fever can be concerning, it doesn't necessarily indicate an immediate need for surgery. Similarly, option B notes a vegetation size of 5 millimeters. Vegetation size is important, but small vegetations often can be managed medically unless they cause complications. Option D refers to mild mitral regurgitation, which by itself isn't usually an emergency. Option E is a positive rheumatoid factor, which suggests an autoimmune component but doesn't directly point to urgent surgery. The critical point here is option C, recurrent emboli despite appropriate antibiotics. This indicates that, despite medical therapy, the embolic events are continuing, which suggests that the infection or the vegetations are not being controlled. This ongoing risk of embolism can lead to serious complications, such as stroke or other ischemic events, and often warrants urgent surgical intervention to remove the infected material. So, the key takeaway is that persistent embolic phenomena despite optimal medical therapy is a clear indication for urgent surgery. It highlights the importance of monitoring and acting swiftly in such high-risk situations to prevent further morbidity. This ties back to our overall theme of timely management in infective endocarditis to improve patient outcomes. The correct answer here is C, and I want to highlight why that's the case. Recurrent embolization, heart failure, or uncontrolled infection are really the key indicators for early surgery in these patients. When emboli keep happening, it suggests the problem isn't resolving on its own, and that can pose serious risks. Heart failure indicates that the heart's ability to pump effectively is compromised, which is another urgent sign. And if the infection is uncontrolled, delaying surgery could lead to worsening systemic issues. So, these factors, recurrent embolization, heart failure, and uncontrolled infection, are major reasons to move forward with surgery promptly. This ties into the overall theme of timely intervention to prevent further complications and improve patient outcomes. Let's take a closer look at some of the high-risk features associated with infective endocarditis. First, prosthetic valves are a major consideration because they provide a surface where bacteria can adhere more easily, making infections more difficult to treat. Next, S. aureus bacteremia is particularly concerning because this organism is highly aggressive and can quickly lead to endocarditis if it enters the bloodstream. IV drug use is another key risk factor, as repeated injections can introduce pathogens directly into the bloodstream, increasing the chance of infecting the heart valves. Embolic phenomena are also important to recognize. These are signs that parts of a vegetation or infected material have broken off and traveled elsewhere, potentially causing problems in the brain, spleen, or other organs. Additionally, the development of a new murmur or signs of heart failure can be a clue that the infection is damaging the heart valves significantly. Overall, these features highlight the importance of early recognition and prompt management of infective endocarditis to prevent severe complications. Let's talk about diagnosis. When suspecting infective endocarditis, blood cultures are essential. Ideally, you want to obtain at least 3 sets from different venipuncture sites to improve the likelihood of detecting the organism. This helps confirm the infection and guides targeted therapy. Next, imaging plays a crucial role. Starting with a transthoracic echocardiogram, or TTE, is usually the first step. However, if the results are inconclusive or if there's a high suspicion, a transesophageal echocardiogram, or T, provides better visualization of the heart valves and can detect smaller vegetations or abscesses. Finally, the Duke criteria combine clinical findings and microbiological data to establish the diagnosis. They help classify cases into definite, possible, or rejected infective endocarditis, providing a structured approach to diagnosis. All these tools together, blood cultures, echocardiography, and the Duke criteria, are key to confirming infective endocarditis accurately and timely. Let's take a closer look at some of the key indications for ICU admission in our patients. First, acute heart failure is a critical condition where the heart suddenly can't pump enough blood to meet the body's needs. It requires intensive monitoring and management. Next, septic shock, which is a severe infection leading to dangerously low blood pressure and organ dysfunction, also demands ICU care to stabilize the patient and administer appropriate treatments. Another important indication is stroke or embolism, where rapid intervention is essential to minimize brain damage or prevent further clot migration. Conduction abnormalities, such as those caused by an aortic abscess, can lead to dangerous arrhythmias or blockages, making ICU monitoring necessary. Finally, infective endocarditis, an infection of the heart valves, often involves complex management with antibiotics and sometimes surgical intervention, requiring close ICU supervision. All these conditions highlight how critical and complex these situations are, emphasizing the importance of ICU in providing continuous, specialized care to improve patient outcomes. Let's take a closer look at some of the key surgical indications for infective endocarditis. When the heart failure is caused by valve destruction, surgery often becomes necessary to repair or replace the damaged valve and restore proper heart function. Recurrent emboli are another critical indication. If the infection or vegetations are breaking off and causing emboli repeatedly, surgery can help prevent further complications. Persistent bacteremia, despite appropriate antibiotics, suggests that the infection is not being controlled and may require surgical intervention to remove infected tissue. Additionally, the presence of a perivalvular abscess indicates that the infection has extended beyond the valve itself, which often necessitates surgical drainage or removal. These indications underscore the importance of timely surgical management to prevent severe outcomes in infective endocarditis. As we continue, remember that these factors are central to deciding when surgery is essential in managing this complex condition. Let's talk about some key pearls when managing infective endocarditis. First, never ignore the presence of S. aureus in blood cultures, because this pathogen is highly aggressive and requires prompt attention. Next, when dealing with prosthetic valves, a transesophageal echocardiogram, or T, is absolutely mandatory to get a clear picture of what's happening. If the patient is stable, starting with blood cultures is a good first step before jumping into more invasive procedures. And finally, surgery can be life-saving, but it's reserved for selected patients where medical therapy alone isn't enough. Keeping these pearls in mind helps us make better, more timely decisions and ultimately improves patient outcomes. Thank you so much for being here today. I really appreciate your time and attention throughout this presentation. I hope what we've discussed has provided valuable insights and practical takeaways for you. Remember, the key points we covered, whether it's the importance of innovation, collaboration, or adapting to change, are all essential to achieving success in our field. I encourage you to take these ideas and apply them in your own work. Again, thank you for your engagement and participation. I look forward to seeing how you implement these concepts moving forward.